Σας καλωσορίζω λοιπόν, λέγομαι Φράγκου Μαρία, είμαι συντονίστρια του Επιστημονικού Τμήματος Αθλητικής Φυσικοθεραπείας του Πανελληνίου Συλλόγου Φυσικοθεραπευτών. Σας καλωσορίζω στον πρώτο κύκλο διαδικτυακών ημερίδων του Επιστημονικού Τμήματος Αθλητικής Φυσικοθεραπείας. Αισίως έχουμε φτάσει στα μέσα Ιουλίου και σήμερα η ημερίδα μας έχει μια ιδιαιτερότητα εφόσον γίνεται στις 10 το πρωί και υπάρχει λόγος που γίνεται αυτή την ώρα, διότι έχουμε καλεσμένα μας τον κύριο Peter Malliaras από την Αυστραλία. Εκεί είναι βραδάκι από ό,τι βλέπουμε. Οπότε δεν θα μπορούσαμε να κάνουμε την ημερίδα μας στις 9 η ώρα το βράδυ όπως έχουμε συνηθίσει. Θα ήθελα να ευχαριστήσω τα μέλη της Συντονιστικής Επιτροπής του ΕΤΑΦ, τον αντιπρόεδρό μας, τον κύριο Δούκα Αντώνη, τον γραμματέα, τον κύριο Μουτζούρη Θεοφάνη, την κυρία Ιγνάτο Γλουδέσποινα, που είναι επί των δημοσίων σχέσεων, και τον κύριο Τόλο Ηλία, καθώς και τη γραμματεία του Πανελληνίου Συλλόγου Φυσικοθεραπευτών και τον κύριο Μπρί για την τεχνική υποστήριξη. Είναι πάντα κοντά μας και τον ευχαριστούμε πάρα πολύ γι' αυτό. Είναι χαρά μας και τιμή μας να σας έχουμε κοντά μας και να είστε αρρωγοί στην προσπάθειά μας, και εφόσον μιλάμε για αρρωγούς, δεν θα μπορούσαμε να παραλείψουμε το Κεντρικό Διοικητικό Συμβούλιο του Πανελληνίου Συλλόγου Φυσικοθεραπευτών. Και έτσι μαζί μας, από ό,τι βλέπουμε και τον πρόεδρο των φυσικοθεραπευτών και τους αντιπροέδρους μας. Οπότε, κύριε Λιμπερίδη, έχετε το λόγο. Καλή σας μέρα.
Και τον υπεύθυνο δημοσίων σχέσεων που μας έδωσε,
τον κύριο Μουτσούζη Λευτέρη,
και ο κύριος Αυτοσμίδης. Είμαστε όλοι εδώ, παρόλο που είναι η μέρα εργασίας. Αυτή τη στιγμή είμαστε όλοι στα εργαστήριά μας, οι περισσότεροι, εν πάση περιπτώσει. Καλημέρα, good morning, Peter Malliaras. Good afternoon, μάλλον, γιατί εσείς έχετε εκεί απόγευμα. Από την όμορφη Ελλάδα. Το σημερινό θέμα που αφορά τον αχιλλαίο τένοντα, νομίζω όλοι οι φυσικοθεραπευτές έχουμε προβληματιστεί πάρα πολλές φορές με αυτήν την πάθηση. Εμείς στην Ελλάδα ξέρουμε για τον αχιλλέα, ξέρουμε πώς πέθανε, πώς σκοτώθηκε μάλλον από τον Πάρη, που βρήκε το βέλος στη πτέρνα που ήταν το ευαίσθητο σημείο. Προφανώς ο αχιλλαίος τένοντας έχει σχέση με αυτήν την ιστορία, με αυτόν τον μύθο που είναι και η ιστορία. Εν πάση περιπτώσει, όλα έχουν λίγο Ελλάδα, ειδικά στην ιατρική. Ένα τόσο ενδιαφέρον θέμα σήμερα, κλείνει παρένθεση, ένα τόσο ενδιαφέρον θέμα από έναν τέτοιον επιστήμονο ο οποίος βρίσκεται στην Αυστραλία και τον έχουμε τη χαρά να είναι σήμερα μαζί μας. Συγχαρητήρια στη Συντονιστική Επιτροπή του Επιστημονικού Τμήματος Αθλητικής Φυσικοθεραπείας. Κλείνει ο κύκλος αυτών με πολύ ενδιαφέρον που παρακολουθούμε αυτών των ημερίδων που μας κράτησαν συντροφιά και στην περίοδο αυτή του lockdown, αλλά και συνεχιζόμενο μέχρι σήμερα. Βλέπω ότι είναι αρκετοί συνάδελφοι που παρακολουθούν, παρόλο το ακατάλληλο της ώρας λόγω του πρωινού, αλλά δεν γινόταν διαφορετικά. Όλη η Συντονιστική Επιτροπή έκανε έναν αγώνα και βέβαια και τη γραμματεία, όπως είπατε, και την ψυχή των ηλεκτρονικών μέσων του κυρίου Μπρι, ο οποίος είναι πάντα παρόν και μας βοηθάει και μας έχει απλοποιήσει, εφαρμόζοντας τις αποφάσεις της διοίκησης όλο αυτό το σύστημα για την παρακολούθηση, εν πάση περιπτώσει, των ημερίδων από τα μέλη. Να μην ξεχνάμε ότι ο Σύλλογος σταματάει μέχρι εδώ τις ημερίδες από εδώ και πέρα, γιατί όπως γνωρίζετε τέλος Σεπτέμβρη έχουμε τις εκλογές του Συλλόγου. Πήραν μια παράταση από το Μάιο και είναι 26 Σεπτέμβρη. Έτσι να καλέσουμε όλους τους συναδέλφους να συμμετέχουν για να δυναμώσουν το Σύλλογο, την επόμενη διοίκηση, γιατί θέλουμε συμμετοχή εμείς. Η διοίκηση, οι διοικούντες, όσοι ασχολούνται με τα κοινά, θέλουμε συμμετοχή. Προσπαθούμε τα μέλη, να εξυπηρετούμε τα μέλη, να εφαρμόζουμε πολιτικές οι οποίες έχουν σχέση και με τη συνεχιζόμενη εκπαίδευση, όπως είναι η σημερινή εκδήλωση, αλλά και με όλα τα υπόλοιπα, αλλά και οι διοικήσεις του κάθε περιφερειακού τμήματος και βέβαια της κεντρικής διοίκησης θέλουν τη συμμετοχή των μελών. Έτσι λοιπόν θα καλέσω εγώ τα μέλη να συμμετέχουν στις εκλογές, να συμμετέχουν στις διαδικασίες τις συλλογικές του Πανελληνίου Συλλόγου Φυσικοθεραπευτών. Ένας Πανελληνίος Σύλλογος Φυσικοθεραπευτών που έχει κάνει πολύ μεγάλα βήματα τα τελευταία χρόνια και θα κάνει ακόμα περισσότερα, και νομίζω ότι το καταλαβαίνουν και το αντιλαμβάνουν τα μέλη. Να μην μακρηγορώ, νομίζω ότι και ο κύριος Τόλος θα έχει λύσει το τεχνικό πρόβλημα. Καλή επιτυχία λοιπόν. Ευχαριστούμε τον κύριο Μαλιάρα για τη σημερινή του παρουσία και συγχαρητήρια πάλι στη Συντονιστική Επιτροπή και σε εσάς, κυρία Φράγκο, για τη σημερινή εκδήλωση.
Ευχαριστώ, Πέτρο, και ευχαριστώ, Μαρία. Θα αρχίσω τώρα. I apologize again that I'm going to be talking in English today. My Greek, unfortunately, is not good enough to do the whole presentation in Greek, but I'm happy to be here, and thank you very much for the invitation to come and speak to everybody today. I live in Melbourne, which is one of the biggest cities in Australia, and both of my parents are from Greece. My mum is from Rhodes, and my dad is from Tripoli. So I lived in London for 5 years. I got back from there 10 years ago, and I was going to Greece every year when I was living in London. And my Greek was much better then, but unfortunately, here in Australia, I don't speak much Greek at all. But it is a beautiful, beautiful, beautiful country, and I can't wait to get back. The last time we were there was 5 years ago. So it's definitely a pleasure to be here and to be able to connect with Greek people again. I'm happy to take questions as we, if you want to write the questions in the chat and then I can answer them at the end, I'm very, very happy to do that. So this is Melbourne, and Melbourne is very much known for sport. So this is the MCG, which is a big football stadium in Melbourne, and it holds about 100,000 people. So we have every week people go to the Australian rules football, and that holds about 100,000 people there. We also have obviously lots of other sporting events like the Grand Prix and the Melbourne Cup. So it's a famous city for sport. I was going to be going to, as people probably know, Australia is very diverse and a very different country. So I was going to be going to the north part of Australia, which is called Darwin, for a holiday. I was meant to be leaving on Saturday, but that's been cancelled because of our latest lockdown, which just started here, as people might be aware, unfortunately. So we're staying home, and all the kids, I've got 3 kids, they're very, very upset, but that's okay. I know you guys have been through some lockdowns as well in Greece. So I work at Monash University, and at Monash University, I mainly do tendinopathy research. So tendinopathy research primarily on the Achilles tendon, but also on some other tendons as well. I work in a clinic, and I work in a private practice 1 day a week, and I see in this private practice only tendinopathy patients and primarily Achilles patients. So the bulk of what I see these days is Achilles tendinopathy in terms of clinical practice. So we're going to try and cover a fair few things. I'm going to try and keep it as clinical as possible today. We're going to talk a little bit about the biomechanics and function of the Achilles tendon. We're going to go into the diagnosis and differential diagnosis of the Achilles tendon. We're going to talk about staging based on pain, so low tolerance, but also based on the continuum model of Jill Cook and Craig Purdom. We're going to talk about risk factors for tendinopathy, and particularly for Achilles tendinopathy. We're going to go into load management. We're going to talk a little bit about adjunct therapies, so other therapies that you can also do to help your patients with an Achilles tendon problem. We'll talk about biomechanics, kinetic chain, and assessment of calf function. And then I also want to talk about exercise and education. Okay, so we're going to cover a lot of different areas. Just let me know if you want me to talk slower, or let me know if you want to translate if people are not understanding. Okay.
Okay, I believe that we don't have any problem to translate. So yep.
Thank you. Continue.
And share your experience.
Thank you very much. Okay, so We know that tendon is a soft tissue. It's a highly organized connective tissue. So it's primarily made of collagen, and collagen that is very, very organized, so that it is very specialized for transferring tensile forces. It's very good at transferring tensile forces. So it's the strongest tissue in the body for transferring tensile forces, even stronger than bone at transferring those forces. And the main reason for that is because of the collagen structure and how well organized that collagen structure is. So it's a very, very strong tissue. A good analogy for the strength of the, and this is from, you might know this person, his name is Carlos Pedres. He's a researcher from Spain, and he has an analogy where he likens the collagen to a very highly organized army, so that they're so organized together, they're very, very strong. And what we know about collagen is that collagen, what we know about the tendon, is that normal tendon doesn't rupture. So we sometimes see tears, and we see all sorts of different pathology within the tendon, but we know that for a tendon to rupture, and it's common for an Achilles tendon to rupture, it has to be pathological. So it can't rupture unless it's pathological already. So the tendon is so strong that it just won't rupture unless there is pathology there already. One of the really important and interesting things about a tendon is that it acts like a spring, okay? It acts like a spring to store energy and then release energy. And that mechanism is very important because it allows us to be more efficient. So you think about the cost of movement for humans and for animals like kangaroos. The cost of movement is mainly based on how much energy it takes to drive our muscles. So that's where the movement cost comes from. And that's where most of the metabolism goes to. But with a tendon, it's completely passive. So we have a spring in our bodies that stores energy and then releases that energy to allow us to do certain movements like jumping, running, walking. And that storage and release of energy is completely passive. So it doesn't cost any energy at all. And that's really, really important. And it's the reason why we can walk for hours and hours and hours without getting fatigue, because most of that activity is occurring in the tendon. Okay, so the tendon stretches and releases that energy to allow us to move. And this process is called the stretch-shorten cycle. And it doesn't happen with all movements, okay? It happens with certain movements. So it generally happens when we're doing things that are fast and quick. So if you're doing things like walking, running or jumping, you generally will get the tendon storing energy and releasing it. And that is, and that's what we generally relate to this stretch, shorten cycle mechanism. So that's important for us because we know that with these stretch, shorten cycle activities, the tendon is loaded quite heavily. So you get a lot of tendon load, and it's a high load activity. So when you're dealing with an Achilles tendon patient, always ask about how much walking they're doing, how much running they're doing, how much sprinting they're doing, because they're the activities that load the tendon to a high level. So those are the high loading activities. And those are also the stretch, shorten cycle activities where the tendon stretches a lot, okay? So it's a really good mechanism, this stretch, shorten cycle, because it allows people to be more efficient, but it also is the time when they are loading much higher in the tendon and therefore at risk of injury, okay? So injury generally happens when people have a change in stretch, shorten cycle activity. So they start some running or they start some more walking. Those types of things are risk factors, okay? Because they're high load for the Achilles tendon. And there's a difference between stretching or slow movements and things that involve stretch, shorten cycle, like walking, running, and jumping. The difference is that when you're doing stretch, shorten cycle activities, it's dominated by the tendon. So the tendon is the thing that is stretching. The tendon is the thing that is taking load. When you're doing things like calf raises and things that are slow, like stretching, then it's the muscle that is being stretched. It's the muscle that is taking load, okay? So there's a real difference between doing fast and slow activities in terms of the tendon versus the muscle load, okay? And that's why walking, running, and jumping, these stretch, shorten cycle activities, they're very high load for the tendon, and they can definitely lead to tendon injury. Okay, so think about those in your assessment. And if we take an example, this is an example of comparing two activities. So this person here on the left is doing a maximal force through their calf, and they're pushing as much weight as they can. So an MVC, maximal voluntary contraction, and this is an isometric hold in plantar flexion for 5 seconds. And we know that you can produce quite a bit of force with this. So most people can produce, upwards of 120, 30, 40 newtons of force. And that could translate to, say, 3.6 times their body weight. So a lot of load through the Achilles tendon, and strain the Achilles tendon by 5%. So the relative stretch in the tendon is 5%. However, when you're doing hopping, so just a simple submaximal hop where someone's just hopping on the spot, the actual body weight load in the tendon is almost double. So you can actually get up to about 6 times body weight load in the tendon just by doing a submaximal hop, which is really surprising when you consider that, to an MVC. And if we think about this in a rehabilitation context, it's hardly ever that we get our patients to do a maximal, MVC contraction in rehabilitation. Generally, we're doing calf raises and other activities that are very submaximal. So we can see with this that hopping and running are really high load for the tendon compared to doing things like rehabilitation. So there's a big gap. There's a big gap between what we do with our patients for exercise and rehabilitation and what they need to do if they're going back to running and those types of activities, okay? So we need to be aware of that gap. When we see patients in the clinic, they tend to present to us with pain and disability. So the way they come to our clinic is they have pain, and that's probably the primary complaint, but they also can present with disability where they say, I can't run as fast or I can't run as well as what I used to. And what we know is that underlying that is a pathology process, okay? So in terms of the pathology process that we see with tendinopathy, we tend to look at this with ultrasound mostly, and I'll talk you through this ultrasound image. So what we see is we see a darker tendon, which is called a hypoechoic tendon, and that relates to disorganized or inferior quality collagen within the tendon. We also see an ingrowth of blood and nerve vessels, and this is an attempt to heal the tendon, and it turns out to be a failed healing response because it doesn't quite reach a point of completely healing for most people. But we see an ingrowth of blood and nerve vessels as well within the tendon. We can see this with Doppler Doppler ultrasound. So that's the underlying pathology process, but we know that pathology and pain are not so correlated. So we know that some people will have the pathology but will not have any pain, and that's really common, especially with people who are older and especially with people who are very active. So we can't base the diagnosis on imaging. The diagnosis has to be clinical, okay? So it's a clinical diagnosis. Let's talk a little bit about the diagnosis then. So this is just a summary of some of the key findings and some of the key things that you look for in terms of diagnosis. So with an Achilles tendon problem, it's generally going to be very localized pain. So the pain is going to be pinpoint either in the mid portion of the tendon or at the insertion of the tendon. So it is quite localized pain. It doesn't refer up or down. Generally, it's very localized to the tendon. Usually they have a history of changing activity, and that change in activity is change in stretch, shorten cycle activity. So it's change in walking, running, jumping, as we talked about before. Usually they're aggravated by stretch, shorten cycle activity. So if you ask them what activities make you worse, they'll generally say it's the running. So with running, they might warm up at the start of the run and feel a little bit better, but then towards the end of the run or the next day, they feel worse again. And they could be worse for 2, 3, 4 days after. So that's a common pattern, and it's usually with the walking, running, or jumping activity. They tend to have a proportional load-pain relationship. So what that means is that the more force you put through the tendon, the more chance that there is going to be pain. So if we go back to this, if you do an MVC, there's going to be less chance of pain than if you do a hop, because the hop is more force for the tendon. Okay, so there's a proportional load pain relationship. So we talked about the warm-up behavior, and the other feature that you generally see is morning stiffness. So when they wake up or when they've been sat down for a while, they stand up and they're stiff and sore. Okay, so that's really, really common, and we see that with our patients all the time. So these are the key features for a diagnosis, and it is a clinical diagnosis. So mainly you're looking at clinical factors. We'll talk about how you can confirm that with the assessment later on. The other thing to be aware of is some of the other diagnoses that can also occur with a tendinopathy. And because of time, I'm just going to focus on mid-portion Achilles tendinopathy, and we'll talk about some of the differential diagnoses for mid-portion. So one of them is paratenon. Okay, so paratenon is obviously the sheath around the tendon, and we can see fluid or thickening around the sheath in the tendon. So this is just an ultrasound, and the paratenon, usually you can't see it at all, but in someone who's got a paratenon issue like here, this is a cross-section of the Achilles tendon. And this is paratenon fluid you can see around the outside of the tendon. So that's quite common to see in someone who's got a paratenon component to it. But as you can see in this image, it's often associated with a mid-portion pathology. So it's not often something you see by itself. It's often secondary to a mid-portion pathology. With the paratenon, if it's symptomatic, they often get pain on the outside or inside of the tendon, wherever the fluid is, or it's a bit more diffuse. So they get pain, but it's up and down the mid portion, not in one spot, as it usually is for the mid portion people. The other one to consider and think about is Plantaris. So Plantaris usually, well, it's on the medial side, as we know, of the Achilles tendon, and it will give you pain on the medial side of the Achilles, and that's the key feature for a Plantaris tendon. They will report pain and point to pain on the inside or medial side of the Achilles. Another diagnosis is the sural nerve. so peripheral neuropathy. And here they tend to have pain that goes down the lateral side of the Achilles and also then into the lateral part of the calcaneum. And that is usually associated with some burning pain. There's no motor referral or branch to the sural nerve, so it's just a paresthesia. And then the other one to consider is a rupture. Obviously, rupture is something that we don't want to miss. And most of the times by doing the squeeze test on the calf or the Thompson's test, we can easily pick up a rupture. The one that's hard to pick up is a partial tear. And partial tear, we can spend a whole lecture talking about partial tears because it's a very debated area, what exactly a partial tear is for a tendon. I'm going to show you an example of a partial tear that I saw recently. So this is an Achilles tendon in cross-section. And this is the tendon here, and it's thickened and it's abnormal. And there's also this here, which is a benign cyst. So that's nothing to worry about. That's just a benign cyst, which you sometimes see. But here is a partial tear. And you can see that the superficial part of the tendon has been torn. Okay, so the point that I want to make about a partial tear, though, is that you have to make the diagnosis on the background of clinical history. So it's impossible to diagnose a partial tear from imaging because you will see things like this, but they won't have the history of having an acute episode. So with a partial tear, there needs to be an acute episode, an acute onset, some sort of incident, something that happened that then caused that tendon to tear. Otherwise, it's not a partial tear, it's most likely progressive degeneration. Okay, and that's a very important point because they're often confused clinically, even by radiologists. They are confused because they see the pathology, but they haven't got the history. So a partial tear has to have a clinical history of an acute episode, and it's usually quite a severe or significant acute episode that accompanies that partial tear. Okay, so again, the diagnosis is clinical. For all these things, you look, first of all, clinically, and then you look to confirm them with imaging, okay? There's also an accessory soleus. So the accessory soleus is when people have a soleus muscle that inserts very low down near the bottom of the Achilles. So some people have an Achilles tendon that's 10 centimeters long. Other people have an Achilles tendon that's 1 centimeter long, the free tendon. So, you know, it's how long is that free tendon? And that can sometimes give you like a compartment syndrome pain where they are running, jumping, and it just gets pressure, just like compartment syndrome. And then when they stop, the pain completely goes away. Okay, so that's also a diagnosis to look for. It's very uncommon, but I see all of these regularly because I see a lot of Achilles tendons, but then some of these are not very common. So sural nerve, Plantaris, not very common. Accessory Solice, not very common. Some of these other ones, Paratinin, quite common to see that associated with the mid-portion Achilles. So that's a little bit about diagnosis. We sort of talked about these images and what they represent. Let's talk a little bit about the continual model. So Jill Cook was my PhD supervisor, and she's just recently retired actually from her university job at La Trobe University, which is another university in Melbourne. Part of my PhD, we did some imaging studies on patella tendon, and they were imaging studies. Longitudinal imaging studies in volleyballers over a volleyball season, and we looked at the imaging changes. and we saw that imaging changed from what was referred to by Jill in this continuum model as reactive imaging, where the whole tendon becomes a bit thicker and a bit darker. And then for some people during the season, we saw that they progressed to more of a more localized lesion that involved a disorganized matrix. So the difference between a reactive and a degenerative tendon is that the matrix is irreversibly affected with a degenerate tendon, whereas with a reactive tendon, the matrix is still maintained and it's just a thicker, darker tendon. So it's most likely related to an increased amount of ground substance, okay? So an increased amount of water binding proteins. So that's a really, really good model for pathology. And it does, I think, help us with pathology because it tells us that, okay, these ones that are degenerate, they're going to be much harder to heal from a pathology point of view. One of the things that it doesn't help us too much with is pain, though. There was an initial thought that maybe the ones that were reactive were the ones that had more cellular activity and were more painful, and the degenerate ones were less painful. But it's very hard clinically to tell what the pain is like and what the cellular environment is like based on a scan. So what we know now is that actually we can look at a tendon that looks degenerate and we can look at a tendon that looks reactive, but the pain and the cellular environment for those tendons is impossible to predict. So we don't know what sort of pain that tendon has by looking at an image. So it doesn't help us in terms of our management. Okay, so in terms of management, we can't really get many clues from the imaging. It's useful, as I say, to sort of tell you, okay, is this going to heal or not? But it doesn't tell us how to manage that tendon. The thing that does tell us how to manage is pain. So in clinical practice, I use pain as the way to, I guess, stage and to manage tendinopathy. Okay. I look at the definition of load tolerance. So this is the key thing that you must do to stage tendons in terms of pain. So there's two parts to it. First of all, it's how much pain do they have during activities that are high load for the tendon. So how much pain do they have during walking, running, jumping activities? How much pain do they have during, and how much pain do they have after? And that gives you an idea of how tolerant they are to load. So if they've got a lot of pain during those activities and it takes a long time to settle, so days to settle after they've done a run or a walk or whatever it is, then they're load intolerant. Okay, and that is the simplest way to stage and then to decide what the management for that tendon is going to be. And we'll talk about that in a second, how to do that. So I usually use just a 0 to 10 numerical rating scale, or even you can use the mild, moderate, severe. And if they've got pain during activities that are high loading, like hopping or running, that is mild, or sort of 1, 2, 3, 4 out of 10, that's acceptable. If they've got pain that is more than that, that's not acceptable based on the definition of load tolerance. And then you would be looking to try and implement something to improve their pain, which we'll talk about in a second. Let's apply this to a clinical case. So this is an example of a 24-year-old male 1500 meter runner, 2-month history of right Achilles mid-portion pain. Worse, so when they do a track session, their hopping pain is worse for 4 days. So they have pain on the hop test that goes up and it stays up for 4 days. And single leg hop, their pain, when you see them in the clinic that day, their pain is 7 out of 10. Okay. So the question is this person load tolerant or load intolerant? And based on our definition, we would have to say that they're load intolerant because their pain is lasting for more than a day after they do something that is high load, like a track session. So it increases for more than a day. And also their pain when you see them that day in the clinic is unacceptably high, 7 out of 10. So this person is load intolerant. And you can define them as load intolerant based on that definition. And then you know that for that person, the key approach is going to be load management. And we'll talk about that in a second. But you're going to need to try and reduce the provocative activities to try and bring about some reduction in their symptoms, okay? So remember, load tolerance definition, ask them about how long it takes for their pain to settle, and you want it to settle if it goes up with activities like high load activities, settle within 24 hours, and also ask them what is how much pain they have with a series of loading tests like jumping, hopping, calf raises, running, etc., that you can do in the clinic with them to assess how much pain they have. Okay, so that's a really, really good assessment for staging and knowing, and we'll talk about how to use that in a second. Okay. The other thing to consider in your assessment is risk factors. So one of the key parts of our assessment is going to be assessing risk factors for tendinopathy for that particular athlete or that particular patient. And we know, we've talked about already, the biggest risk factor is load. So change in running, walking, jumping is the biggest risk factor. But we also have changes, and those changes could be training errors, could be starting pre-season, it could be increasing intensity, increasing volume, it could be changes in training surface or footwear. So we need to explore all of those in our assessment, but we also consider intrinsic factors. So intrinsic factors can also influence the amount of load that a particular person can take before they develop an injury. So if the person is very weak, potentially they have flexibility issues like ankle dorsiflexion for an Achilles. Potentially they have biomechanical issues, and we'll talk about some of these later on. Potentially they're overweight. Metabolic disorders. So for example, we know that cholesterol is a big risk factor for tendinopathy. Same with diabetes, hypertension. Hormonal factors. We know that females in menopause or young females who run a lot and they have amenorrhea or irregular menstrual cycle, they are also at risk. So that is like with bone injury, it's also a risk factor for tendinopathy. So these are important things that we need to ask in the assessment. And then there's also things that are intrinsic factors, but not modifiable. So things like past history of an Achilles or other injury, age, older people. Not so much gender for Achilles because it affects both equally, I think. It really depends on the other factors more. Some people have a genetic history. So I saw a patient on Monday who's a footballer here, and he has just ruptured his Achilles on one side and he previously ruptured the other side. There's most likely a genetic predisposition there. Family history, always ask about family history. So do the parents have tendon injuries or ruptures? Because the genetic links are very strong. Now, we can't really do anything about the genetics, but we can have an idea that that patient might be a little bit harder to manage if they've got a strong genetic predisposition. Exposure to drugs, so multiple steroid injections, fluoroquinolone antibiotics, they will increase the risk of tendon problems in the future. So we need to be careful and ask about those as well. So I think it's important to get a good history of exactly where that patient is in terms of their risk profile. And we can address a lot of these risk factors here. So we can address metabolic disorders with physical activity, same with weight, and we can also address strength and biomechanics. We'll talk about some of that as we go through. So then, when you're starting to do the rehabilitation, there's two phases that I break up tendon rehabilitation into, and just keep it very, very simple. The first phase is stretch, shorten, cycle, load management. So this is when you've got someone like the athlete we saw, the 1500 meter runner in that profile I showed you. You've got someone who's load intolerant. And then the key for them is to make them load tolerant as quickly as possible to reduce their symptoms. And this is what I call the load management phase. So load management phase, the first phase when you're trying to reduce pain. The second phase, when the pain is under control and their loading tests pain is minimal, then you can start to bring in the stretch, shorten, cycle, load again. So then you can start running, jumping, hopping, start, eventually track sessions, competition over obviously a number of weeks. So they're the sort of two phases. But throughout the whole time, you're doing exercise and education. So the whole time along the bottom here, you're doing exercise and education and potentially adjuncts, like, manual therapy, shockwave, other things that we can talk about. So that's sort of the two phases, the two key phases. Let's talk about those in a bit more detail then. So looking at load management, basically what you want to do in load management, if someone is load intolerant, is take their loading that is provocative, i.e. the walking, running and jumping load, down to very little. And I usually my rule of thumb is usually 50% reduction. So if someone is walking, find out how much they're walking. And the easiest way to do that is to gather some step data. So I don't think it's very accurate to ask them, how much you're walking in terms of time. It's often hard for them to answer, but work out if you've got step data. So most people will be wearing a watch where they can monitor their steps and be able to tell you how many steps they're taking every day. Work out the average and reduce it by 50% is what I would generally do. And that's just a really easy rule of thumb. And generally you would do that for maybe 2 weeks, 3 weeks, 4 weeks, and you're monitoring. During that time, you're also doing a lot of adjunct therapies, manual therapy, shockwave, we'll talk about that in a second, to try and maximize the effect of reduction in pain during that time that you have to reduce their load. Obviously, we know it's hard to do that for a lot of athletes because they don't like to do that. They don't like to stop running or walking, and it is a hard thing for some of them to accept and to do. But I think it's really important that we are firm with them to say, this is really, really important. If you don't do this, it's going to drag on for a long time, and it often does drag on for months if they don't load manage appropriately. If they're really intolerant, so they've got severe symptoms like 8, 9, 10 out of 10 with loading and running, then you need to stop everything. And obviously it's hard to stop everything with walking, because walking you need to do a little bit, but you just stop to the just minimal walking they can possibly do if they're really severely intolerant. Okay. The other thing to be mindful of is compression. So this is a really good paper by Jill Cook looking at compression at different sites. For insertional tendinopathies, we know that compression is really, really common, and we need to be aware that some of the things they'll do, like stretching into dorsiflexion, is probably not a good thing because it will compress the insertional Achilles against the calcaneum. So modifying those activities in the short term if they're painful, also modifying their biomechanics they're running biomechanics to reduce compression is something that I'll talk about in a second, okay? Let's talk about adjuncts a little bit. So I've just got a list, and this is not, there's a lot more adjuncts that you can consider, but these are the adjuncts that I find effective in the clinic. These are the ones that I use a lot. So if someone is load intolerant, I will generally always advise that they take anti-inflammatories full dose, and it could be just Nurofen for a week. And at the same time, they're also using ice 2 or 3 times a day for 10 or 15 minutes, putting it onto the tendon. Okay, that just has a good short-term effect on pain, both of those interventions. The other thing that you can do is manual therapy and dry needling. So dry needling, acupuncture, manual therapy, these may have a good short-term effect on pain as well. I don't use them a lot myself because I use a lot of Shockwave. So I do Shockwave in the clinic with a lot of patients, as a way of trying to modulate their pain and trying to reduce their pain. So I don't use manual therapy and dry needling as much, and that's just because I do Shockwave a lot, okay? The other things that I use a lot are heel wedges and tape, and I'll talk to you about exactly which ones of those two I do. So these are things that I do in the clinic routinely with a lot of Achilles patients. You can also refer to, usually I refer to sports doctors to have an injection if someone is really struggling after a few weeks of trying all these interventions, usually at least 8 weeks. If they're not doing well, then either a PRP injection or a high volume injection or a steroid, but usually I try and avoid steroid, could be something to consider. I'll talk about those injections a bit more later on, okay? Hopefully we'll have time towards the end to talk about the injections. I just wanted to make clear that when we're talking about the evidence base for tendinopathy, it is strong with some interventions, but not very strong with other interventions. So for example, exercise and shockwave therapy have been shown to have benefit over wait and see in most studies. So there is pretty good evidence that exercise is probably effective versus doing nothing, and the same with shockwave. However, when you compare to placebo, which is a different comparison, there's uncertain evidence for most things in tendinopathy. So placebo, if you're developing a medication, like a drug treatment for, say, hypertension or whatever it is, you would have to have evidence that it works compared to placebo. And it's much easier, obviously, to have a placebo comparison for a drug intervention as opposed to some interventions like exercise. But regardless, placebo is an important comparator, and we don't have enough evidence at the moment that we know that some of the interventions we do work. I think we've got enough to have confidence that exercise and shockwave work, and my rationale for the others, like acupuncture, massage, injections, is use them if they're not harmful and they're cheap and accessible to you. But if they're very expensive for the patient, then we really need to be thinking about whether these are the best things that we should be offering our patients, okay? So that's how I sort of try and rationalize it, but be aware that the evidence is not very developed for some of the things that we do, okay? So I'll show you specifics of the heel wedges that I use. So these are the heel wedges that I use with Achilles patients. They're called clearly adjustable heel wedges. And if you do a Google search, they come up. And I don't know if you can buy them. You can probably get them shipped, but they're very, very, very good heel wedges. They're hard. They're really not compressible, so they don't compress at all, and they're 1.2 centimeters lift, so they're really good heel wedges. We did a trial on these that we published in BJSM last year, I think it was, and we showed that these heel wedges were as good as doing exercise over 12 weeks, which is really amazing to think that you can just give someone the heel wedges and they were as good as doing the exercise for 12 weeks. So these are the ones that I use now, and I combine them with exercise. So a lot of the patients will get these heel wedges plus the exercise. Okay. They cost about, in Australia, I buy them for $25 each. And I stick this stuff on the top, a soft top with glue, and then make the edge here very smooth with a grinder, and then we sell them for about $80 to patients. So it's part of their management and part of their treatment. So that's an intervention that I find really, really effective. The other thing that I use a lot is augmented Lodi tape. So I use this a lot just to take some pressure and load off the Achilles for a lot of patients. There's a YouTube link to it here if you're not familiar with it, okay? So that's a good adjunct for, again, someone who's load intolerant. And as I mentioned, the other thing that I use a lot and I quite like is the shockwave therapy, okay? Shockwave therapy, I just find it is a good pain modulator. Some people experience a little bit of benefit, other people experience a lot of benefit where they feel that their pain is pretty much almost gone, and it's gone for maybe a week, 2 weeks after they have a treatment. So I usually target the painful areas, and it should be a little bit painful when you're doing the intervention, and then monitor the hopping afterwards. So see how much pain with hopping they have after and before and after, and they should have less pain. And if they do have less pain, then we persevere, and we might do 2 or 3 or 4 sessions of shockwave. So I use that as an adjunct. It's also a really good way to keep the patient coming back in, and that's not to make money, but more so to reinforce all the education and the exercise. Okay, because we know that patients, we give them exercise education, they go away, they do the wrong thing, they don't do it, they haven't got the motivation. So I find with the shockwave, they come in for 3, 4, 5 weeks for the shockwave, and during that time, I'm watching the exercise, progressing the exercise, and you end up getting a much better outcome if you see them often, I think. So that's also a benefit of the shockwave. So let's talk about exercise a bit. This is a systematic review that we wrote a few years ago now, but it's still pretty relevant, the findings. It was Achilles and patella tendon rehab programs. And what we found is that there's lots of different exercise programs. There's the Alfredson eccentric, which you guys will be aware of. There's the Stanish and Kerwin program, which is a bit of an older program. There's the Silbernagel program. There's also the heavy slow resistance, which is different. It's going into the gym and then just pushing heavy weights in the gym. So they do seated calf raise machine. They do standing calf raise loaded, and I think also calf raises in a leg press machine. So there's different programs, and I guess the point is there's so many different programs, so many different reps and sets, but they all seem to be pretty effective. When we looked at this review, we found that even though the programs were very, very different, they all sort of had a reasonably good effect if you did them over a few weeks. So it seems to be that if you're looking at pain as the outcome, it doesn't really matter how the exercise is implemented or what type of exercise you do. It still seems to be effective as long as it's progressive over time, and you're making sure that whilst they're doing it, they're still load tolerant the whole time, so they're not getting too much pain. and their pain's certainly not getting worse as they're doing it. So that was interesting. But it's also important to consider function. What the issue with the literature is that most of the time, the main outcome is pain. And as physiotherapists, we are really good, I think, at improving function and strength. So one of the things that we do very, very well is to get people stronger. And that's very important for them because they get back to function, they're running, they're doing the activities they want to do. So I think it's important to consider function, not only in the muscle, but also the tendon function. And to do this, we have pretty good evidence that you can't do any old exercise program. Like it's the case with pain, where any exercise will improve pain over time if you give it enough time. With loading the tendon and the muscle, we know that it is really dependent on the exercise that you do. So for example, heavier, more intense exercise interventions are probably better for adaptation in the tendon. And they're also better for developing maximal strength in the muscle as well. So my rationale, and in the clinic, I use mainly loaded, heavy, progressive exercise for Achilles tendon. Not with everyone, depending on their goals in terms of what they want to achieve, but mainly with the athletes, I would do a bit more of a progressive, heavier program. And that's based on the evidence that the tendon will adapt better if you do a heavier program. And this is a paper that we did when I was working at Queen Mary University in London. And we basically looked at adaptation of the patellar tendon with different types of loading, heavier versus lighter, eccentric versus concentric. And what we found is that eccentric, concentric loading led to equivalent tendon adaptation as long as the load was equalized. The thing that the tendon really responded to was heavier load. So if the load was heavier, it was much more likely to lead to adaptation or strengthening of the tendon. So that is that's a good reason to consider doing heavier load interventions. And it doesn't have to be with all the exercises, but at least with one of the exercises that you might do. Let me give you an example of this is a typical loading program that I would use for an Achilles patient. So I tend to use seated calf raise. So doing a seated calf raise over a step if they have mid portion, on flat ground if they have insertional tendinopathy, and loading the calf raise really, really heavy. So getting up to 1.5 times body weight on the bar, okay? So I'll give you an example of the Achilles rupture patient that I said that I saw on Monday. He's 88 kilos. He's used to be a professional soccer player, but now he's a coach for one of the professional teams here. So he's not, he's a bit heavier than what he was when he was playing. He's 88 kilos. And he needs to get to the goal we set for him on the seated calf raise machine when I saw him. This is 12 weeks after surgery for rupture, is 130 kilos. So that was his goal. And we set that on Monday. And it'll probably take him 3-4 months to achieve that. But that's what he will work towards. And then in standing calf raises, he will work towards half his body weight. So he's going to work eventually to 44 kilos. And this is all single leg. So 44 kilos of added weight to the bar. With the bar. The bar might weigh 10 kilos, it might weigh 5, it might weigh 20. Whatever the bar is, make the total weight 44 kilos for that person. So that's how I try and set a target for the person to get to. I think it's really helpful for the athletes to have some sort of target, to know that that is the goal they're going for. You can also do endurance. So generally with endurance, they're doing 2 sets, getting to 25, 30 repetitions. It might depend on their age. We'll talk about that in a second. So generally they're doing this 3 sets of 8 for the heavy load, 3 times per week, and progressing over time. Okay, so that's the general program that I would use for a lot of Achilles athletes. For someone who's sedentary, so just going back to walking, it's very similar, but I probably wouldn't do a lot of seated calf raise, more the standing calf raise, and not getting to 0.5 body weight. Some of them just get to their body weight, and that's enough. Some of them get to 5 kilos, 10 kilos. Really depends on their age and how much walking they're doing and how fit they are. It will be less than what you would do for an athlete. The exercise that I use a lot more for sedentary people is the calf wall sit. So this is the calf wall sit, and you can see that the heel is elevated here. So the heel is off the ground and the shin is vertical, and then they've got 45-degree angle in the thigh, and they hold there for 30 seconds by 5. And that's a good alternative to the seated calf raise for someone who doesn't have a gym or someone who's more sedentary going back to walking. Okay. Now, isometrics, obviously it's really, has become very popular, and it's from the work of Ebony Rio. And Ebony Rio is another PhD student of Jill Cook, and she had a paper in patellar tendon that showed that the pain with loading straight after isometrics was very much reduced, and that became very popular, and people developed the view that isometrics was really good for pain relief. But unfortunately, what has happened since then is that many groups around the world have tried to replicate Ebony's study, and it hasn't been the same results. So this is probably the best one, and it was published 2 years ago. And they showed here that whether you do isometric or whether you do isotonic, it doesn't actually lead to any difference in immediate pain response. So you still get the same pain response immediately after. So I don't think it's a good reason to do isometrics for immediate pain reduction. In fact, I don't use it much for that. You can for in-season athletes. It could be good for in-season athletes because they isometrics are good for in-season athletes because they don't get as much fatigue. So that is a good reason to do isometrics for the in-season athlete. You can do it every day and they don't get as much fatigue. But the reason that I use isometrics is for load tolerance, and it's primarily for people who are unable to do isotonic. So if you're doing your progressions here that we talked about, and the person is finding up and down too painful, load intolerant, so they might have a 6, 7 out of 10 pain, then just switch to an isometric, and switch to an isometric in a mid-range position. And that generally is going to be much better tolerated by the person. So they won't have as much pain, and they can do the exercise. So that's how I generally use isometrics. Not so much for immediate pain response, but more so for developing tolerance when they're very painful with the isotonic. Okay, so it can be quite useful for that, and I do use it quite commonly for that type of presentation. All right, so let's switch focus to a bit of biomechanics now, okay? So I'm going to talk a little bit about biomechanics in relation to the Achilles. So if we're dealing with a runner, one of the things to look for is, I believe the biggest biomechanical issue with running is overstride. when it comes to the Achilles tendon. Now, people sometimes find that a bit strange because when you're running with a higher cadence, you tend to land more flat foot. So you tend to use the calf more in initial contact. But the problem with the overstride is that if you're overstriding a lot, when you get to mid-stance, you tend to have a lot of dorsiflexion range, and they tend to have excessive dorsiflexion, and therefore they tend to get overload of the Achilles. So the time when the Achilles is loaded the most in running is in mid-stance, particularly when you're running with a big overstride. So look for dorsiflexion in mid-stance, and if they run with a higher cadence, they've got much less dorsiflexion in mid-stance because they're not on the ground for as long. And because they're not touching the ground, their contact time is less. They haven't got time to go into as much dorsiflexion, okay? So that really helps them. So cadence cues are very, very, very important for these people. Now, I'm not saying go on to running on their toes, because that can be quite also a lot of load and a big change for people with an Achilles problem. But running with a more midfoot strike is optimal. And the best way to achieve that is just to focus on cadence cues. For the walking patients, the thing to look at, again, is dorsiflexion. So a lot of the walking patients, if they're walking with long strides, they're going to get a lot of dorsiflexion, and they're, again, going to be overloading their Achilles tendon. The other thing to look for is pronation with the walking patients. So pronation, mid-stance, or in terminal stance dorsiflexion. Now, one of the things that is helpful for this is the heel wedges. So the heel wedges that we talked about, the 1.2 centimeter heel wedges, that will really take load off this. The other thing you can advise them is just to walk with smaller steps. So smaller stride when they're walking, that can really be helpful to reduce in-range dorsiflexion. The other thing that I look at closely with running patients, particularly runners with Achilles tendon, is hopping. Okay, so let's look at this guy hopping. He's got the right foot there, and then he's got the left foot, and you can see the left foot is a lot smoother. Okay, you can see the right foot. It quickly goes into dorsiflexion, so he hasn't got the control into dorsiflexion that he needs, and he's much smoother on that side. So you can see issues with hopping, and often they're related to control of hopping, and it can be related to pain, it can be related to weakness, and then we need to assess that and determine what the interventions are going to be, whether we want to strengthen the calf or reduce the pain. But generally, for a lot of these patients, especially running patients, I'll get them onto a hopping program, okay? And I'll talk to you about the hopping program in a second. The other thing with the athletes is to measure their power, okay? So measure something like maximal forward hop by 3. So what they do is 3 continuous hops. So 1, 2, 3, and then you measure what the distance is. Most patients will start off somewhere like 3-4 meters, but they might get to 4.5-5 meters on their good side, and then you start to work on that as part of the rehabilitation. And this is, you might have someone who's a soccer player or some other athlete where you're working on this as part of their rehabilitation. So that's the one that I generally do in clinic mostly, and that's 3 hops for distance. The other thing you can do is measure their hop heights. So the height of hopping, and generally on single leg. This is the MyJump app, and the MyJump app is an app that you can buy which allows you to measure jump height pretty accurately. Okay, as I say, I don't use it much myself because I prefer to do the hopping for distance. but it is another option. Okay, so let's talk about calf function. Okay, so now measuring, the next thing I would do after I've assessed biomechanics is looking at the strength in the calf, how much function and strength I have in the calf. So here, just general calf raises. You can do it over a step if it's mid portion, or otherwise flat ground if it's an insertional. The key thing with calf raises is technique. So make sure you go all the way up into plantar flexion, all the way down into dorsiflexion. Make sure they're pushing over the big toe. They're not rolling out to the outside of the foot, as a lot of people do. Make sure that the body is upright and they're not swaying forwards with their body, or they're not bending their knee forward, and that often is related to weakness in the calf. And make sure they're doing it very, very slow. So tempo of 3 seconds up, 3 seconds down. Okay, so it's a really good test, but you have to be very conscious of their technique when they're doing it. This is normative data. So this is data looking at how many calf raises you should be able to do depending on what age range you're in. So if you're in your 30s, you should be able to do about 32 calf raises, maybe a little bit less if you're female. If you're in your 40s like me, you should be able to do 28 calf raises for men. Once you get to your 70s or 80s, that drops down to about 10 calf raises. So it's very, very low. And obviously there's a decrease with age. So this is good. This is important for understanding what level should they get to, how much strength do they need to get to with their endurance for calf raises, okay? So if you've got a patient who's 20 and they can do 10 calf raises, which is very common, you can say, look, this is not the level you need to be at. You need to be much stronger. And that's also good motivation for the patient to actually think about improving their calf strength. The other test that I do in the clinic is seated calf raise. And I would just do seated calf raise, 6 repetitions for the maximum weight they can push. So 6 repetition maximum. And generally, you're looking for runners 1.5 times body weight. Okay, for recreational athletes, for walkers, for people going back to walking, generally they're about 1 times body weight, maybe 1.1, maybe 1.2 times body weight. Okay, and that's generally what we're looking for. So here's an example. So this person is doing the seated calf raise. You can see she's over a step here, and she's going all the way down and then all the way up. Okay, all the way down and all the way up. So that's a really good test to assess how much strength they have in the Achilles and in the calf. Now we've got a paper coming out soon, hopefully. It's under review at the moment, where we have identified that runners who don't have an Achilles problem should have 1.5 times body weight strength with a seated calf raise. When they have an Achilles problem, they usually have around about 1 times body weight or even less. So, so that's a real problem and an important thing to look at. Okay, the other thing to assess is kinetic chain. So look at, I look at a few things in the clinic with my Achilles patients, and I including the posterior chain. So looking at the hamstrings, and that could be with a leg curl or a bridge, looking at the quadriceps, and usually I use a leg extension machine to assess the quadriceps strength, and then looking at hip abduction, and I usually use a pulley machine. So this is just my clinical assessment. If you don't have access to these machines in your clinic, then you can use bands, you can use other types of, compound sit to stand, squatting, single leg activities to assess the strength, okay? But it's important to get an idea of how much strength they have throughout the muscles in their kinetic chain as well. Because often you see issues, especially with the older patients, because they'll have a history of, knee OA or a history of, other problems, and they'll have weakness because of that problem that could be contributing to their Achilles as well. So let's then turn our attention to education. This is an editorial that I co-authored with a few other people, and in this editorial we put forward how important it is to develop an effective working alliance. So develop a relationship with the patient to try and improve the patient's self-efficacy. So their belief that they're going to get better, their belief that exercise and education is going to help them. Because, a lot of patients come and they just don't have the confidence that that exercise is going to help them. Then trying to address any barriers to them having a successful outcome. So, for example, some people are fearful that if they have pain, they're going to cause more damage or they're going to cause problems, and addressing those beliefs about their pain. And that all comes down to really good education. So education is a very critical part of rehabilitation for these Achilles tendon patients. And then also thinking about adherence. So we know that exercise is a major part of treating these people. And we know that people, when they do the exercise, they generally get better. But it's hard to sometimes get them to do it and stick to the exercise. It's very hard for some people. So trying to address adherence is also important. So education is important. I think as physiotherapists, we don't have the skills that are developed enough in education sometimes, because it's just not one of the things that we are taught, and we have to develop those skills with experience in the clinic over time. And it is a challenging thing to do. This is just a summary of the key education points that I try and cover for patients with Achilles tendinopathy when I'm seeing them. So I think patients want to know what is the problem and why have they got the problem. So we need to explain that it's a pathology of, as we said earlier, failed healing response. We need to explain that the risk factors, as we talked about. We need to reduce their fear about pain. So we need to make sure they're not thinking that if it's painful, they're going to cause more damage. They'll also have questions about what they can do about it. What can they do about the pathology? And I think it's important to say to patients that we can definitely improve their function and we can improve their pain, but their pathology may not completely reverse. It may not completely improve. And I'd say that to patients because they feel like the pathology is the problem. That's what they want to get better. But realistically, a lot of the times the pathology doesn't completely get better. And we're treating function and pain and restoring their function and pain. We also need to tell them about the treatments. And I think it's important as physiotherapists that we don't limit ourselves to just talking about exercise. And we need to say, these are the treatments that are available. So when I treat an Achilles patient, in the first session, I'll write down every single treatment that they can possibly have, right from massage, injections, surgery, shockwave, exercise, education, and the benefits and harms of each of them. very briefly, obviously, but it's important for them to know that there are injections available. This is the evidence. There are surgeries available. This is the evidence. So they can make informed decisions about what they want to do. Then we also need to educate them about loading and the exercise evidence briefly, and load management principles and the importance of load management. And the other questions patients generally have is, how long will it take? So how long will it take them to get better? And I think it's important here that we are realistic about that tendinopathy is a difficult condition to treat, and it usually takes months to get better, as we know. It's important for the patient to know that we're going to do everything we can to get this better as quickly as possible, but it often takes months, and it's a difficult thing to manage. But there are options. If you're not improving, we're going to think about this next option like Shockwave, or we're going to think about an injection or something else. So it's important to have those discussions of their options and pathways from day one, and how difficult it is, and be realistic about the outcome. So education really is important, and you keep on, obviously reinforcing this as you see the patient. You keep on reinforcing the education. All right, so let's move to the second phase then. So the second phase of so we've done all this good work now. We've looked at biomechanics, we've assessed the calf function, the kinetic chain, we've done some rehabilitation, we've done some adjuncts, and hopefully you're getting the pain better, and they're starting to get stronger, and you're starting to think about returning to running. So let's just take running as an example. My clinical decision around return to run is based on pain at the moment, mainly. I'm not too fussed about the strength when they're returning to running, because I know that they're going to return gradually. So with the pain, you want their pain to be minimal on the loading tests that we talked about earlier. So say hopping or any of the other loading tests that you're doing, you want the pain to be minimal. And that's the time when you can start thinking about running. And generally starting with a very basic running program, I would generally get people to do a few minutes of running. So it could be 5 minutes, could be 6 minutes of running, add in 2 or 3 minutes per run. And they might run 3 times a week. So adding 2 or 3 minutes 3 times a week. So then by the second run, they can run 7 minutes, and then 9 minutes, and then 11 minutes, etc., etc. And you've got to give them the advice that if it's starting to get worse, so you start to feel like there's a bit of pain with running, that's normal. But if the pain lasts for days, that's not normal, and you should reduce, just rest until the pain recovers again, and then run again in 2, 3, 4 days, whenever it is. So try and give them that advice, because it often does happen that they have problems when they first start to run. So try and develop the volume of running, and then eventually when the volume is good, then go to the speed work and track and everything else that follows after that gradually. One of the things that I do with most running patients these days is add in a hopping program. Now, this is a program that we've developed ourselves, and we've got one study that has investigated the safety of this hopping program so far, but I usually do it in parallel. So I get them to run twice a week, and then they hop once a week. So they're running, say, Monday and Wednesday, and then hopping on a Friday. And with the hopping, double leg hopping, double leg jumping, single leg hopping with a stiff knee, and that's just faster, so really fast. I'll show you a video of this in a second. And then forward and back, side to side, and then hopping onto a box. Generally, they bring it in gradually. So they might do the first week, these two, and then they bring in the rest over 2 or 3 weeks. So let's have a look at a video of hopping. So this is the double leg jump. This is the double leg jumping, and then single leg hopping faster, and then forward and backwards. And it's really designed to bring about recovery of power. So most people with Achilles problems have issues with hopping. It's a high load activity. They have confidence issues. They feel scared to hop a lot of the time. They also have pain with hopping. They also have reduction of power and strength with hopping. So it helps with all of those problems. And if you bring it in at the right time, it's very safe. And we showed this in a study. So we did a study where we looked at the safety, a single cohort feasibility study that was published 2 years ago. And we showed that it is safe to bring in hopping as part of rehab for Achilles tendinopathy. The next step is to do a trial where we look at the effect of adding hopping and to see if there's better outcomes when we add hopping. So that's the next step. But at the moment, we know that it's a safe thing to do if we add hopping into our Achilles tendon rehab. So consider hopping as part of your rehabilitation as well. I just wanted to talk a little bit about difficult presentations. Often in the clinic, you will come across people who are finding it very hard to progress. They've seen a lot of people. Often it's related to either a lot of fear avoidance, so they have a lot of fear and psychological stress, and that's a barrier to them progressing with the exercise, doing the exercise. Another category that is difficult is the metabolic patients. So these are patients that are generally overweight, they've got cholesterol, commonly with insertional Achilles, you see very overweight people, and they've got metabolic issues. They're very hard to manage. For them, I generally would recommend mainly weight loss. And obviously it's hard because they've all tried to lose weight before, and often they haven't been successful. But if they can, and if you can convince them to do something that's going to help with their weight, it often is the best thing they can do for their Achilles, far better than the rehab that we offer. So I usually refer them to an exercise physiologist, and they would try and work with that person to increase their physical activity. Autoimmune problems like rheumatoid arthritis, gouts, other inflammatory problems, they can be difficult. I guess the key thing with them is to make sure that you're thinking, has this person got an inflammatory problem? Often they have bilateral, they have not any loading change. So they've got this tendinopathy, but there was no change in activity that brought it on. So that's a real problem, and often something that's related to the inflammatory side of things. They might have a history of not responding to exercise, really poor response, or getting flared up a lot with exercise. Send them to a rheumatologist if you think that there's any chance they have an inflammatory problem. Family history, we talked about that a bit. So if you think that this person is, some people are just, really predisposed genetically, and picking up a family history is really, really important. For some people, you can sort of have an explanation as to why their symptoms are not improving, as with some other people. So this is a video that is actually on, it's a video that's on YouTube, and basically it just goes through some of the main education points for tendinopathy. So you may or may not have seen that, but have a look at that. There's a link to the Vimeo site there. So that is the first. That's I can finish there, and we can take questions. I've got some other slides just about common errors that people make. And then I've got some other slides about a bit more detail on the injections, as we talked about. But I think what I might do is just stop there and take some questions. Is that okay?
Is that okay? Thank you, Mr. Malliaras, very much for this very interesting presentation. We noticed that tendon stores energy, and this is the reason that has the pain and disability. It's important to understand the model which explains the clinical presence load in this tendinopathy. We have to notice how much pain during and after activities that is acceptable pain. 0 to 10, you said. We have to explain the pathology, the causes, and keep in mind difficult presentation that you say. Exercise and shockwave therapy will require the hard work for months. Oh, that is difficult. Will hit conflicting effects of Achilles load, low dye tape. You said so much information about the tendinopathy that it's very interesting. Now I will the administrator of the discussion is Tolos Ilias. So I called Tolos to do the conversation, the discussion.
Thank you, Maria.
Δεν ξέρω αν ακούγομαι τώρα.
Yes, it's okay.
Ωραία.
We hear you.
Ωραία. Να ευχαριστήσω και εγώ με τη σειρά μου, πρωτού προχωρήσουμε λίγο στη συζήτηση, τον κύριο Φουσέκη και τον κύριο Στασινόπουλο για την δυνατότητα που μας έδωσαν να επικοινωνήσουμε με τον κύριο Μαλλιάρας. Και περιμένοντας τις ερωτήσεις σας είτε στα ελληνικά είτε στα αγγλικά, θα αρχίσω λίγο τη συζήτηση με τον κύριο Malliaras στα αγγλικά και θα προχωρήσουμε στις ερωτήσεις. So, Dr. Malliaras, thank you very much for being here with us. It was an excellent and very solid and clinical presentation. In order to wait for questions to come up, I have one question for you. You showed us some normative values concerning heel raises, and there was a comparison between men and women, males and females. And I noticed that females in their 70s or 80s have better values than males. Can you explain this?
Let's have a look. It's a good question. It's interesting, isn't it? It is interesting. I actually am not sure why. You can see that females start lower, much lower, but then their decrease in strength is actually lower over time. So you're absolutely right. I'm not sure why that is. I'm not sure why. It could be related to differences, physiological differences in aging between men and women. I'm not sure if they exist or not, but that could explain it. It could also be related to differences in how men and women use their ankles over time and injuries. So, for example, the sports that men do predispose them to more injuries and therefore more weakness over time. So I'm not sure, but it's a good question.
Or maybe hormonal issues, probably.
Quite possibly, quite possibly. Quite possibly. Yeah, I'm not sure. I'm not sure.
Okay. So we are still waiting for questions. So I would like to ask if some of the board members would like to make a comment in Greek, of course, so as to wait for next questions. Οπότε αν ήθελε να μας κάνει ένα σχόλιο ο κύριος Λιμπερίδης, ο κύριος Ρουμελιώτης, τα μέλη του Κεντρικού Διοικητικού Συμβουλίου, μέχρι να έχουμε καινούριες ερωτήσεις. Κύριε Λιμπερίδη.
Εγώ να συγχαρώ τον κύριο Μαλλιάρα και εσάς βέβαια, και στην Συντονιστική Επιτροπή, παρόλο που ήταν πρωί, όσο μπορούσαμε παρακολουθούσαμε την ομιλία. Να περιμένουμε τι θα μας πούνε οι συνάδελφοι και οι φοιτητές που παρακολούθησαν, ποιες ερωτήσεις θα απευθύνουν και πιστεύω ότι θα είναι πολύ χρήσιμη και η επόμενη συνέχεια της συζήτησης.
Ωραία, ευχαριστούμε πολύ. Θα ήθελε κάποιο άλλο μέλος να κάνει κάποιο σχόλιο μέχρι να δούμε κάποιες ερωτήσεις ακόμα. Να κάνω εγώ άλλη μία ερώτηση, εφόσον δεν βλέπω κάποιον να θέλει έτσι να σχολιάσει, να ρωτήσει ακόμα. So I would like to make another question, Dr. Malliaras. You talked about shockwave therapy, and you mentioned the continuum model of tendinopathies. So I would like to ask if you use shockwave in all types of tendinopathies.
I do, yeah, I do. I use shockwave in all types. I use shockwave in all types of tendinopathy. I think that with the continuum model, it's important to differentiate whether we're talking about the continuum of pathology or continuum of pain. So with the continuum of pain, it goes from load intolerant to load tolerant. And I would use it with, regardless of how severe the pain is, I would still use shockwave. With the people who are more load intolerant, you can use the shockwave very gradually, so it is not as painful initially. So obviously with a shockwave, you can modulate how many bars of pressure you put on. So you just use it very, very gradually and then increase the bar if they're having a good response. So that's fine. Even with reactive versus degenerate tendons, so if we're talking about the continuum of pathology, I still would use the shockwave with all of them. So pretty much with all patients, I would consider it, but you just got to modulate the pressure. I see it as very much a pain modulatory treatment. We're doing some research at the moment. I've got one PhD student who's doing a trial, and he's looking at the short-term effects of shockwave therapy. So shockwave therapy has always been considered something that is going to have some sort of healing effect on the tendon. And it's going to have some stimulatory effect on cells leading to healing. What we know now is that what we see with our patients is that it has a strong short-term effect. So it's like doing manual therapy or dry needling, where you can do some technique on the patient, like shockwave, and they report their pain is better immediately. And it could be better for a few hours or a few days afterwards. So we're measuring that effect. So with this PhD student, in his trial, he's going to measure how much pain they have before and then immediately after, and then for 5 days after the shockwave. And we're going to try and see whether there is a short-term effect that is measurable with shockwave therapy. So maybe that will lead to different treatments for shockwave, but I primarily use it as a pain modulator, regardless of the pathology, regardless of the pain. Okay?
Θα ήθελα να ρωτήσω και εγώ τον κύριο Μαλιάρα μέσω εσού, Ηλία. Έχουμε διαπιστώσει πολλές φορές στους αθλητές μας, στους δρομείς κυρίως, ότι με την αλλαγή παπουτσιού πολλές φορές δημιουργούνται διάφορες τενοντοπάθειες στον αχιλλείο. Υπάρχει κάποια έρευνα σχετική που αφορά το υπόδημα του αθλητή?
I understood most of that, Maria, but not all of it. It's something about shoes, changing shoes, and then the onset of Achilles tendon problems from shoes, and whether there's any research backing that up.
That's right. Yes, that's right.
Thank you. So I think with the research for with the shoes, there's probably a couple of problems. One is the design of the shoe in terms of how much lift there is, or how much heel lift there is in the shoe. So when athletes go from, say, training in regular shoes to training in track shoes, say spikes and track shoes that are flatter, that can be a problem because there's less heel lift. So they can then develop a tendon problem. So the problem really relates to how much lift there are in the particular shoes they're wearing. The other issue is the other possible issue is rubbing. So with some shoes, especially with insertional problems, they can get just friction of the insertion, and particularly if they've got a Haglund's deformity. The bump at the back of the Achilles, of the back of the calcaneum, they can get rubbing and friction. So a lot of people do get issues with rubbing, and then it's trying to find comfortable shoes for them, or trying to cut out the heel counter of the shoe. The other thing to consider with shoes is that often if they're wearing shoes and they've got an acute onset of tendinopathy with just shoes, you've also got to consider whether the friction is the problem, and maybe they've got a bursa or they've got a paratenon issue. So they can often get paratenon or bursa just from the fact that they're rubbing as well. So so there's a few things to consider, but I agree. The change of shoes is a time when you do see a lot of tendon problems. That's a real important thing to consider as part of an assessment. But unfortunately, there's not much research on it at all that I'm aware of.
Okay.
Yeah.
Okay.
Okay. There is a question. So concerning the commencement of exercise in our rehabilitation program, can exercise be started at the beginning of the program, or shall we wait for some decrease in pain first and then start exercise?
Yeah, that's a really, really good question. That's a really, really good question. So I think it is important to have a very individualized approach. Let me just share my screen again, and I'll show you this. I think it's important to have an individualized approach. When you're looking at a patient, assess their load tolerance, and then try and understand where that patient is in this continuum. So the continuum from requiring load management to being acceptable. So on this continuum, they can have very high load test pain where you know for sure this patient needs load management, or they have very low pain and acceptable pain, because a lot of patients come to us and they haven't got much pain at all. They might be fearful of exercise because they think it's going to cause pain, but they haven't got much pain, or they might have already load managed because they stopped running 2 months, 3 months before they saw you, so their pain is low. So they present in all different ways depending on how much provocative loading they're doing at that time. So it's absolutely fine to start running or even maintain the running if their load test pain is low and acceptable. But I always base it on the load test pain. So if they can hop, for an Achilles patient, if they can hop with minimal pain, generally you can start them running, and or you can continue the running. You don't have to stop the running. So that's okay. But if they're doing maximal activities, so say they are a sprinter or a soccer player and they're doing things like they're doing sprinting, then it's very important that they also have good strength. Because if they're doing maximal activities, like sprinting, they really require maximal strength. And then you need to think about their strength. So I'm happy to do submaximal activities day one, even if they've got minimal pain, even if they've got suboptimal strength. But eventually you need to take them to that level of strength that they need to be at in order to do maximal activities.
Okay, now concerning the gradual return to running, there is a question about when should the recreational runner or patient increase their running distance, and how much increase would that be every time? I think you mentioned that in your presentation, but give us a comment about that.
So if I understood that correct, it is how much increase over time to do with the runners.
Yes, I think that is the question.
Yeah. Generally, I always am conservative initially. So initially you might do, say, 5 minutes. If they haven't run for a long time, say they haven't run for 2 months or 3 months, then you have to be very, very careful. If they haven't run for a year, you have to be really, really careful, because they will definitely find it very hard initially. So if they haven't run for a long time because of pain and tendinopathy, then you have to start very gradual. And I think 5 minutes of running, and then add 1 or 2 minutes every session, every second day. And then if they're okay with that, then you can, maybe after 3 weeks, you can be up to 20 minutes. And then if they're okay with that, you can maybe start moving faster, where they, instead of 1 or 2 minutes, they add 3 or 4 minutes every run. And then if they're okay with that, you can build to their volume, whatever volume they want to do. So if it's a marathon runner, they want to run for 1 hour. Once I can get them running 1 hour 3 times a week, then we start thinking about more of intensity and starting to do some speed as well. So then they might start, they have one run where they do 1 hour, and they have one run, another run where they do 1 hour, then they have another run where they start to do some speed work. Then eventually they might add another run where they also do speed work. And then they start to work on things gradually. So I guess the principle there is to change one thing at a time and gradually build up the volume. Once they achieve a volume that is good, then you can start working on intensity. Initially, it's important that they're really gradual to make sure that they're not getting flare-ups. So it is a bit individual, because you will be thinking about how is this individual responding to that amount of load, and how is that individual going. So it's individual. You can be faster for some people, slower for other people, but base it on the response they're getting in terms of their pain.
So I guess during your assessment, you take into account their previous workload or training load in order to make this individualized program. Okay.
Yes, exactly.
Okay, great. There is another question. I'm not sure if I can translate it correctly, but I will. So if we have an athlete who is painful before, during, and after the activity, if we follow a proper rehabilitation, can we return this athlete to a better or a previously better level, or will he be injuring himself in the following days or weeks or months or years with this same injury?
Yeah, it's a great question.
With
recurrence.
With the recurrence and the long duration of the rehabilitation program.
Yeah, that's a great question. So it's having a tendinopathy is always a risk for a future tendinopathy. So they'll always be at greater risk, but you can manage that risk by making sure that their strength is very, very good. So that's why I really have the strength targets that we talked about. So for example, looking at all these strength targets, I think is critical because the 1.5 times body weight and the 0.5 times body weight. And it doesn't have to be these. You don't have to just use these, but as long as you've got some way of measuring strength and making sure that their strength is good and they've recovered their function. Because I think the biggest risk factor for recurrence is when they're starting to either have suboptimal strength or get back to those activities very quickly. So get back to stretch, shorten cycle activities quickly. So if you give them advice, when you see a patient with tendinopathy, the long-term advice is you're always going to be at risk. You've got to manage your load over the season. So in pre-season, you've got to make sure that you don't go super hard, super quickly, because then it's going to be a disaster in terms of the increase in symptoms. And they've got to manage those times when they're at peak risk of injury after a rest, for example. They've also got to manage the tendon by making sure that they continue with as much of the heavy loading as possible. And obviously with sports people, it's hard because you've got, training 4 days a week and you've got all the other things. So they can maybe do this once, twice a week, but they're trying to maintain that during the season so that they still have got some fitness and strength in the tendon. So those things can mitigate the risk, but it's still going to be a risk going forward. So generally they'll still be at risk of injury. Most people, they get back and the first season might be difficult, so they might still be managing symptoms the first season, and in the second season, by the time they learn to manage it, they're a little bit better and they can start to manage it and be a little bit more on top of it. So it is a case of, with a tendinopathy, learning to manage it a bit as an athlete.
Okay, great. I have another question. You mentioned insoles, you mentioned heel lifts. Yep. And I would like to ask, apart from your research that you've done with these heel lifts, are you aware of any other research articles for this subject? And are you talking about market heel lifts or custom heel lifts insoles? And would you use this for both insertional and mid-portional Achilles tendinopathy?
Fantastic. Good questions. They're basically completely off the shelf, so they're not custom at all. The only thing I customize in these heel lifts is just the top here, the soft part of the top. And sometimes we don't even put that in, but some patients find it hard, very hard on the foot and very uncomfortable. But you can put it under the insole of the shoe. So if they've got a shoe that's got an insole, just put it under. Sometimes that's okay. So they're completely off the shelf. There's no customizing at all. There's no other research that I am aware of looking at the clinical effects, but there is a lot of research looking at the loading effects, so how they affect the Achilles load. And a summary of that research is that if you do put the heel wedge in, it reduces Achilles forces. So there is a biomechanical reason and mechanism for the heel wedges. I've got a PhD student at the moment who is starting his PhD in the next few months, and he's going to look at these heel wedges. So he's going to look at different heights. So higher versus lower. He's going to look at softer versus harder surface material. So we're going to have some good data looking at the biomechanical effects, and then he's going to do a trial looking at the optimal heel wedge that we think is the best one, and then looking at that versus something else, possibly placebo. We're not sure yet. But I use them in insertional and mid portion. So pretty much all the Achilles patients, most of the Achilles patients that I see, unless they say to me that they don't want heel wedges because they find them very uncomfortable, or they've tried them before and they haven't worked for them, then I would recommend them for most people.
Do you think that using that change in their footwear, like increasing the drop of the footwear, would do the same thing?
Yes, yes, absolutely. Yeah. So doing something like footwear modification, like, you know, the Hockers, you know, the Hocker shoes?
I'm not sure about that. Hocker shoes. Hocker shoes. Okay, Hocker, yeah. Hocker.
These are the Hockers. These are the Hocker shoes. I don't know if they're popular in Greece, but they're very popular here. And,
yeah, they are in runners, yes.
Yeah, yeah. So they have a very high heel, and they can be quite good. I recommend these for some Achilles patients if they've got problems with shoes. So I think anything with a high pitch and a high heel is going to be good. And often with females, if they wear a little bit of a heel, it's better. So a little bit of a boot or a little bit of a heel, it's better for females rather than flat shoes. They find that much better. So I think shoes are very, very important as well in terms of advice about shoes.
So you would recommend an increase in drop of more than 10 millimeters, 1 centimeter?
Around about that, yeah. So yeah, a 10 mil pitch is good, something like that. Yeah. Yeah.
Okay, great, great. I don't see any more questions. So it's about 10 past 12 here in Athens, Greece. So I would say that if there are no more comments, we can close this presentation. We would like to thank Mr. Dr. Malliaras. It was a great presentation about this very specific pathology. We could talk about hours for this subject, and maybe we will have the opportunity to have another session with you, Dr. Malliaras, in the following weeks or years. I would like again to thank Dr. Malliaras for his contribution. Now I will ask Maria Fragou to close this presentation in Greek. Thank you very much.
Thank you.
Ευχαριστούμε πάρα πολύ, κύριε Μαλιάρας. Ξέρω ότι αυτά τα καταλαβαίνετε. Είναι Greek. Η Ρόδος τελικά και η Τρίπολη έκαναν έναν πολύ καλό πετυχημένο άνθρωπο που μπορέσε να μοιραστεί σήμερα τις εμπειρίες του μαζί μας και τη γνώση του. Ευχαριστούμε πάρα πολύ. Εδώ θα θέλαμε να κλείσουμε αυτή την παρουσίαση και να σας δηλώσω ότι στις 29 Εβδόμου, την άλλη Πέμπτη, θα είναι το τελευταίο webinar που θα κάνουμε την τελευταία ημερίδα για να κλείσουμε για το καλοκαίρι. Θα έχουμε μαζί μας τον κύριο Τάτσιο Πέτρο και τον κύριο Κουμαντάκη Γεώργιο, οι οποίοι θα μας μιλήσουν για την παθολογία του συμπλέγματος ώμου σε αθλητές. Οπότε σας προσκαλώ και για την επόμενη Πέμπτη στις 9 η ώρα το βράδυ, όπως γνωρίζουμε πάντα, να είστε κοντά μας και θα είναι χαρά και τιμή μας να παρακολουθήσουμε όλοι μαζί τις εξελίξεις στον νόμο των αθλητών πλέον. Κύριε Μαλιάρα, σας ευχαριστούμε πολύ. Για εσάς καλή σας νύχτα. Για εμάς εδώ καλή μέρα και καλή συνέχεια στην ημέρα σας. Να είστε καλά.
Thank you very much. Thank you very much for the invitation. Ευχαριστώ πολύ σε όλους που ήρθατε, and let's keep the conversation open and keep in touch. Okay?
Thank you. Thank you very much.
Keep in touch. All right. Take care. Have a good day.
Thank you very much.